Hello everyone, my name is Brandon Gaucher. I will be presenting case study number 2 for my group. The group consists of myself, Nicholas Bryant, Miriam Quiroga, and Anthony Viscone. So let's go and dive into this case study we have here. This patient is a male, 63-year-old. Ethnicity was not provided to us. The name was kept confidential. The chief complaint was generalized weakness, nausea, and feeling ill. So this patient was brought into the emergency department with that chief complaint of generalized weakness. Some of the associated symptoms were nausea and overall sense of illness. These symptoms started about 2 to 3 days prior to this visit and just progressively got worse to the point that they felt it was necessary for an ER visit. Some of his medical history is that of diabetes, poorly controlled hypertension, which may have easily contributed to some of the symptoms this patient was experiencing. The medications that were listed that this patient was on was an ACE inhibitor, a diuretic, and a sulfonylurea. Past medical history, like I said, was hypertension and diabetes, otherwise unknown. Past surgical history was unknown. Family history was unknown. Social history unknown, and allergies unknown. So over the review of systems, just the generalized weakness, nausea, and illness. Patient was only oriented to self and place, so he was really unable to provide any information that kind of hindered our ROS. Physical examination, BP 154 over 105, heart rate 70, respiratory rate 22, and temp was 36 degrees Celsius. And this patient, like I said, continues to appear lethargic, ill. HEENT, normal conjunctiva, mucous membranes were moist. Moderate bilateral jugular venous distension was noted. Respiratory status had some minor rales bilaterally, cardiovascular rise, normal heart rate, S4 heart tones upon auscultation, no murmurs or rubs were noted. The abdomen was soft, non-tender to palpitation, and no organ megaly was noted. Hypoactive bowel sounds, and the rectal examination was normal. Skin-wise, he was cool and dry. His lower extremities showed some bilateral edema on his knees. So some of the diagnostic tests that were provided to us was a single lead EKG, which kind of limited our evaluation. With the rhythm, it kind of appeared that it was sinus with maybe a Mobitz 2, definitely a widened QRX complex, easily related to maybe a right bundle branch block. Additionally, the rhythm kind of showed some ST depression, and might have been suggestive to some ischemia going on. So a 12 lead is necessary for this patient. So kind of working up our patient, we had 3 differential diagnoses that we came up with, and I will list them in the orders. So our primitive one was hyperkalemia related to acute renal failure, ischemic heart disease, and then congestive heart failure. So we'll go over the evidence that we found that was supporting to these diagnoses. For hyperkalemia, we saw the widened QRS. Like I said, an official 12 lead would be necessary. Acute renal failure, which would give us elevated values. Long-standing diabetes and uncontrolled hypertension. Overall generalized weakness. The edema, the fluid overload, JVD distension, and then just the congestion in the lungs, the bilateral rales. In addition, the patient was, nausea, vomiting, had some weakness, and they're on an ACE inhibitor, which puts them at risk for having higher potassium levels in the serum. As far as ischemic heart disease, some of the supporting evidence was the EKG. Once again, showed a right bundle branch block with the ST depression. S4 heart tones were auscultated, generalized weakness with a gradual increase in that weakness. His uncontrolled hypertension, that blood pressure of 154 or 105, that diastolic was quite impressive. He did have the history of the long-standing poorly controlled diabetes, so definitely more lab work to really fully evaluate his sugar levels. And of course, the patient's skin was cool and dry. Now, as far as congestive heart failure, being as our third supportive, so S4 heart sounds were auscultated. History of uncontrolled hypertension. Once again, that blood pressure 154/105. The moderate jugular venous distension. Rails that were noted in his lungs bilaterally, and then just generalized weakness. Of course, the pit and edema in the lower extremities and cool, dry skin. So overall, we developed a plan of care after we had those 3 differential diagnoses. First thing is this patient needs close eyes and observation, so we're going to go ahead and OK an admission to the ICU. Start to this potentially, so if we're relating more to the oh, I apologize. Let me get back on track here. So admit to the ICU. Definitely this patient needs a chest x-ray. May need fluids, especially if we're thinking acute renal and we need to get those kidneys going, so possibly some NS at 150. We just have to be very close monitor just due to the fact the sodium levels, the potassium levels are elevated this time. We would do a 12-lead EKG. An echocardiogram would be ordered. Just to see how that heart muscle is really doing. Lab-wise, we would get a full panel, a CBC, CMP, an ABG to check his gases. LFT and TSH would be ordered. Albumin levels, possibly a UA with urine electrolytes. Perform a lipid panel and troponin. Foley catheter would be placed just for accurate I's and O's and just to make sure we can really see urine output and see those kidneys function start improving, hopefully. Definitely we need to consult cardiology due to irregularities in the EKG. I believe it would be appropriate to also consult nephrology for that ARF that's present. Really, we need to quickly manage that potassium, so deliverance of kind of a cocktail, so giving calcium gluconate 500 IV over a Q10 over 10 minutes would lessen by 50%. Start them on regular insulin. Albuterol would be beneficial. Definitely some Lasix so we can start pulling some fluid, and if the patient can tolerate, throw some Kexalate. That'll really start motivating the potassium to shift out of the body and be excreted. So some of the questions that were necessary to be answered was based on the EKG, what is the most likely electrolyte imbalance? Everything points to hyperkalemia. It's likely that elevated potassium that needs to be corrected. The evidence-based that emergent treatment, let me repeat the question. What is the evidence-based that emergent treatment for this patient with this electrolyte imbalance? So reduction in serum potassium, this is accomplished just by administering the calcium gluconate, insulin, Lasix, albuterol, and Kexalate. If we're not seeing anything, emergent dialysis if appropriate, but we would allow for nephrology to give us their opinions before anything like that would be started. And then, of course, the 3 differentials that were listed. So the hyperkalemia, kind of the clinical presentations for these would be tiredness, weakness, feeling of numbness, tingling, nausea, emesis, trouble breathing, chest pain, and irregular heartbeats, which many of these are presented in this patient's case. Congestive heart failure, you see weight gain, volume overload, dyspnea, and fatigue. Really just due to the heart not functioning and the cardiac output decreasing. Ischemic heart disease, you might see some acute arm pain, chest tightness, irregular heart rates, increase, and of course shortness of breath with activity, nausea, and vomiting is also present, some sweating and fatigue, stress-induced as well. Question number 4, what is most likely the diagnosis based on this patient presentation? And what is about the patient that makes him high risk for this diagnosis? Well, most likely the diagnosis is hyperkalemia. The patient due to the acute renal failure. The patient is at risk due to the combination of his age, his poor health, inadequate control of his diabetes, and blood pressure. Some of the supporting evidence is that widened QRS, the nausea, the weakness, ACE inhibitors, and the uncontrolled hypertension. The kidney damage is evidence of the long-standing diabetes medication for generalized weakness, fluid overload, the JVD distension, and the bilateral knee edema, and the rales noted along the lungs. So some of the risk factors that this patient has for this diagnosis, this patient is at risk due to the combination of, once again, his age, poor health, inadequate control of his diabetes and blood pressure. Those are huge factors. Some preventative screening should include routine physical exam, subjective and objective data as necessary. Comprehensive labs such as the CBC, CMP, A1C, UAs are also very necessary. So these are definitely things he should be having his PCP provide for him. So if we are having worsening kidney failure with time, we can kind of see that progression and hopefully prevent an event like this. So his long-term kind of plan is he's going to need routine physical exams and follow-ups with his PCP once post-discharge, once we can get him stable enough. Of course, the labs, and then additional screening. Within those labs is we need to check for proteins, albumin, glucose, and protein to creatinine and albumin to creatinine ratios. Frequent screenings of CKD would be necessary since he has a higher risk. Of course, routine blood glucose that he should monitor himself at home in a log so we can see if we need to make adjustments. So really the key points with this patient that we need to be mindful of is we need to treat that hypokalemia, because those are going to cause lethal arrhythmias. While we're treating that hypokalemia, we need to see if the kidneys are going to bounce back and that renal status is going to improve. If not, we need to determine if he needs further treatment, if dialysis is something in the near future. We also need to really find motivational factors to educate this patient. He needs to realize the significance of the damage he's causing when he doesn't regulate his blood pressure correctly, when he doesn't control his diabetes. So maybe we can reduce these hospital emergencies if we can help him better manage his medication. With that being said, I think he definitely do great with the home health eval. Start off with medication education, definitely appropriate for this patient. We will be providing an outline of kind of our plan and kind of our thought process with this video as well. Other than that, that kind of concludes our summary of this case. Thank you very much.